Good afternoon. It is a privilege to be talking to you today about how to combat adolescent suicide in rural Wyoming. My name is Sarah Cleveland, and I will be speaking from the perspective of an epidemiologist. So what I'm going to be talking about today is first a description of the problem, then I'm going to go into my proposed interventions, first a screening for depression intervention, then a treatment for mild depression, and finally a treatment for moderate to severe depression. Then I'm going to go into my proposed evaluations for these interventions, mention some potential challenges or barriers that I see, and then I'm going to present my logic model. So the epidemiology of adolescent suicide can be described by person, place, and time. Research shows that males are most likely to commit suicide, while females are most likely to attempt suicide. And this could be partly because males are more likely to use fatal methods. Non-Hispanic whites have the highest rates of suicide in the United States, and also non-metropolitan areas have the highest rates. So it makes sense that states with more rural geography are most impacted. As you can see from this map I made, the dark blue represents the highest rates of suicide, and Wyoming is one of these states. Now, the most recent hypothesis is that the time of puberty can influence adolescent suicide. Today, the peak puberty is 13 for boys and 11 for girls, which is earlier than normal. So this creates more time for early onset depression. So my problem statement is that suicide among adolescents is an epidemic, indicating the need for both public health attention and societal change. And I would argue that it is an epidemic because no levels of suicide should be normal in our society. Especially from this chart, you can see that girls aged 10 to 14, it is a problem because suicide rates have tripled since 1999. Now, depression has been known to be the most common risk factor for suicide. Other psychological disorders, such as anxiety disorders or bipolar disorder, can also contribute to one's risk. Chronic conditions, including chronic pain, as well as substance abuse, can lead to suicidal behavior. Social determinants of health can be the lack of treatment for depression, and this is partly due to the so-called black box of antidepressants, because we don't know why it can affect people under the age of 26 negatively. Environmental factors, such as stressful life events, can also contribute to depressive symptoms. This can be one particular event or a series of events. And finally, a family or personal history of suicide attempts can determine one's risk. What happens is, if one is surrounded by suicidal behavior, it becomes somewhat normalized in his or her worldview. Now, we can use the social ecological model to see where interventions would most likely be appropriate for this health issue. At the individual level, an inability to cope with stressful life events can hinder healthy behaviors, while early self-identification and treatment can be helpful. At the interpersonal level, dysfunctional family relationships can lead to stress and depressive symptoms. However, support from and a good relationship with one's parents has been shown to reduce these symptoms. At the organizational level, a lack of connectedness in school or to learning in general can lead to depression, but involvement in positive activities outside of the school can be helpful. At the community level, one big issue is inadequate follow-up for people who have had a suicidal episode that has landed them in the hospital. What can help in this situation is integrated mental health services at the local level. Now, at the policy level, the cost of treatment can be a major barrier, especially for those in rural areas. But school policies that report, document, and refer students can help in these settings. So why did I choose Wyoming for this targeted intervention? Well, the Morbidity and Mortality Weekly Report in 2014 reported state suicide rates, and Wyoming had the highest with over 30 per 100,000. The Youth Risk Behavior Surveillance System is a great data source for epidemiologists to use. It shows that in Wyoming, 9.6% of middle school students attempted suicide in 2013, and 30% of high school students felt sad or hopeless in 2015, while 11% attempted suicide. Now, comparing this to the 8% attempted suicide average in the United States, these are pretty high. Additionally, in Wyoming, 60% of adolescents who have had a major depressive episode did not receive any treatment. Now, in Wyoming, there are 178 schools in rural areas, and we wouldn't be going to all of these because we would only be doing this in middle schools and high schools. But 28.6% of all students in Wyoming do go to rural school districts. And so this is a good population to implement a pilot intervention series because it is a small enough area, but with a large enough concentration of students. So my first proposed intervention is screening. The U.S. Preventative Services Task Force and the National Institute of Health and Clinical Excellence recommend universal screening of 12 to 18-year-olds in the primary care setting. However, primary care physicians in rural settings are about 20% more likely not to have proximate behavioral health services available. So we would want to do a school-based screening for this intervention. We would use the Mood and Feelings Questionnaire, which has a child self-report version, and our data would provide physical and psychological symptoms. A physical symptom example would be, I was less hungry than usual. And an example of a psychological symptom would be, I felt that there was nothing good for me in the future. The data would also provide counts on how many students require mental health services and an idea of how common untreated depression is in this population. For the social ecological model, this intervention would fall under the organizational level. So hopefully students will feel more connected to their school during this intervention. My second proposed intervention would be counseling. Determinants such as income, transportation, insurance status, and education level has been shown to contribute to whether or not rural residents seek help. So for this intervention, we would want counselors to come into the community. Brief supportive counseling requires 8 sessions and includes psychoeducation, support, and management of symptoms. These may be sufficient for the treatment of mild depression. However, additional topics can include nutrition, sleep, exercise, and anxiety management. Education for family members has also been shown to be helpful. The bottom line here is that problem-solving interventions has been shown to lead to lower scores of depression and hopelessness compared to controls. The social ecological model for this intervention can fall under both the individual and community levels. The third proposed intervention is an emerging field called telepsychiatry. There are evidence-based benefits for this, including patient and provider satisfaction, which is higher in rural areas than in suburban areas. Treatment outcomes have also been shown to be similar or even better than usual care. Cost savings for rural residents can be achieved within 6 sessions. This is because there are upfront costs, but saving on travel makes it a good long-term investment. So how this would work is that patients would video conference with their psychiatrist, preferably with a computer. However, if those are not available, telephone calls can be used. So assessments, conversations, and questions can be all answered digitally, and medications can be picked up locally just like they are in usual care. The social ecological model level that this would fall under is the policy level. So we would evaluate our screening program with data. Our baseline data would include the number of students in each grade, the number who have been screened before, and qualitative data on the students' perspectives on self-disclosure of mental health information. Our post-intervention data would include the number and percent of students in grades 6 through 12 who completed the questionnaire, the number and percent who require follow-up, and also another qualitative component on the teacher's perspectives on the usefulness of the screening tool. Our measure of success would be 90% coverage. We would evaluate our counseling program by calculating the number and percent of students who score above a 20 on the Mood and Feelings questionnaire. Determinants such as sex, age, and race would help to determine which subpopulations are in most need. Our post-intervention data would include the number and percent of students who were contacted, who began counseling, and then who completed counseling. Our measure of success here would be a 75% completion rate. Then we would evaluate our telepsychiatry program using the rates of moderate to severe depression within the study population at the start, and this would be sourced from the counselor's recommendation. Post-intervention data would include the rates of moderate to severe depression after 1 year. And we would also want to do patient satisfaction surveys to gain information on their experience. Our measure of success here would be a 10% reduction in moderate to severe depression. Now, evaluation efforts can collaborate because we would need parental consent at each stage of the intervention. So through the assessment, the diagnosis, and the treatment phases. Coordination of mental health professionals will also be needed because we do need administrators of the screening tool, we need community counselors, and we need psychiatrists. The rights and responsibilities for all the parties included, patients, parents, and providers, need to be made known because there are special safeguards that need to be in place to protect the privacy and confidentiality of the patients. Potential challenges include the 4.3% high school dropout rate in Wyoming. Now, this doesn't seem very high, but it is above the national average. And so we would potentially lose students who could benefit from this program. Advanced technology or internet access could also be lacking, and we would have to adjust our expectations based on that. And also funding for mental health personnel and services could be a major barrier. So as you can see from my logic model, in order to carry out our activities, we would need materials such as the questionnaire. We would need to develop additional questions on the knowledge and the attitudes about mental health and also the patient satisfaction surveys. We would need the personnel, we would need the funds, and we would need the consent forms at every stage of the intervention. Our activities were the interventions mentioned, our outputs were described in the evaluations, and so our outcomes that we want to achieve are increased coverage of students aged 12 to 18 living in rural areas who are screened for depression, increased outreach to adolescents in need of counseling services, improved access to treatment regimens for students in need of antidepressants, and then ideas on how the program can be improved to better serve the needs of the community in the next year. Now, in light of all of this, our overarching goal would be to impact this population in a positive way. We want to lower rates of depression for adolescents in rural Wyoming and therefore have a reduction in suicidal ideation and suicide attempts. I thank you so much for your time. These are my resources.